Good afternoon and welcome to the Systems for Action Research in Progress webinar series. My name is Anna Hoover. I am the co-director of the Systems for Action National Coordinating Center here at the University of Kentucky. Systems for Action, as many of you know, is a national program of the Robert Wood Johnson Foundation. It is our pleasure almost weekly to bring you the latest breaking research out of cross-sectoral collaboration, cross-jurisdictional sharing, all of those wonderful issues about how we partner together to improve health and well-being nationwide. Today we will be hearing from some of our practice-based research network partners in Connecticut and Massachusetts who are going to share some work they've been doing on cross-jurisdictional resource sharing and scope and quality of public health services. Just want to take a moment to introduce you to our presenters very quickly. Justeen Hyde is a research health scientist at the Center for Healthcare Organization and Implementation Research in Bedford, Boston, at the Bedford, Boston VA. For many years, she has worked with local and state public health departments to develop and implement research and evaluation studies focusing on public health programs, services, and organizations. Since 2008, she has also co-directed the Massachusetts PBRN, Practice-Based Research Network for Public Health, a group that is focused on the study of cross-jurisdictional service sharing as a strategy for improving the equity and quality of local public health services. Joining Dr. Hyde today is Dr. Humphries, a clinical instructor in epidemiology at the Yale School of Public Health, who has a broad background in public health research and practice. Dr. Humphries' research addresses programmatic approaches to improving public health, as well as interactions between nutrition and infectious disease, as well as intersections between, and we are also going to be joined today by a couple of public health practitioners who I will introduce in more depth in a little bit, but we have with us Mr. Huleatt, the Director of Health for the West Hartford-Bloomfield Health District in Central Connecticut, and Mr. O'Connor, who is with the Office of Local and Regional Health for the Massachusetts Department of Public Health. Again, more on those excellent respondents a little bit later in our hour together, but for right now, I'd like to hand the mic over to Dr. Humphries to get us started.
Thank you, Anna. We really appreciate the opportunity to share our work with this group, knowing that the audience is people who are also passionate about high-quality public health services. I want to start by acknowledging our funder, the Robert Wood Johnson Foundation, and the commitment to local public health that they have demonstrated through the funding they provided to this kind of work. So a little bit of background. Connecticut and Massachusetts are interesting states. They are both home rule states, and what that means is that responsibility for local public health resides at the municipal level. In both states, there's a mix of service delivery models. There's independent health departments with one municipality. There's a continuum of partial shared services where you might share certainly the services that have been environmental, sanitarian, and also comprehensive shared services. In Connecticut, we also have districts, which are multi-municipality separate organizations organized to deliver local public health. In addition, both Massachusetts and Connecticut have practice-based research networks focused on local public health. To give you an overview of the two states, Massachusetts, we're looking at a total population with the two states of about just over 10 million. Note that Massachusetts has 351 towns, municipalities, 351 boards of health. Connecticut has only 169 towns, and because of our district arrangements, we're down to 74 health departments. Connecticut districts began in the 1960s, and so we've been working on this kind of sharing since then. Massachusetts has been working on it more recently. As a sort of a fun fact, Connecticut and Massachusetts together represent almost 15% of all of the health departments in the U.S. because of this home rule model that we have. So when we got together, we've been talking, the two PBRNs have been talking about what could we do together. And when the directive RFP came out, this seemed like a really great opportunity for us to work together to look at how service sharing, how cross-jurisdictional service sharing affected quality, breadth, and cost. So what we did is we looked at the sharing. We only used comprehensive sharing because we needed to draw some boundaries around what we were looking at. And so we looked at comprehensive sharing versus independent. And then we looked at cost, quality, and breadth of public health services. We focused on obesity prevention, enteric disease, and food safety as the three primary areas that we were looking at. Doing this project required a large research team, and I just want to acknowledge that the work that Justeen and I are presenting today really represents the contribution of a large number of people. We had regular meetings both at the beginning in looking at tools and process, and then and later as we were interpreting the results and trying to better understand what we were finding. Our methodology, we used a combination of census data to get at municipal characteristics, state and local reported data, such as the retail food inspection, and then in-person semi-structured interviews. These were conducted separately in Massachusetts and Connecticut. We used a stratified sampling design where in Massachusetts, all comprehensive shared service departments were recruited. In Connecticut, we randomly selected 8 districts. And then we looked at the population sizes of each of those member municipalities and then identified non-sharing municipalities in the same population strata. So that we were working really hard to recruit independent municipalities that were as similar as possible to the municipalities that had chosen to share resources. This means that almost all of the municipalities that we looked at are quite small, with only a couple over 50,000. There's 4 focus areas that we're going to look at for this presentation. We really want to look at administration and governance, staff and some of the services offered, a little bit on costs, and then we'll also come back in on quality and some of the qualitative data that we have on the quality of services provided. An overview on the demographics. Note that the sharing and the independence are actually quite similar in poverty rate, unemployment, population, municipal budgets, public health budgets per thousand. These are all per thousand, and race and ethnicity. The one difference that does stand out is the population density is a little bit higher in the sharing department. So turning first to the administration and governance, we asked a number of questions about what the government structures were. You'll note here that the shared has an N of 76. That's the number of towns that were represented by the 15 comprehensive service sharing health departments that we interviewed. And we asked about each of the municipalities and the government structures, both the executive structure and the legislative structure. And there weren't any significant differences in local legislative structure or whether they were rural, suburban, urban between independent and shared health departments. However, it was interesting to note that service sharing departments were significantly more likely to have an appointed administrator. And we can imagine different reasons that might be the case, but this was an interesting finding that that there is this difference here. Some of the other questions that we asked also at the municipal level was to get, and this is just the opinion of the health director or their designee that we were interviewing, but we were asking their sense of the understanding of public health of the people that they worked with at the municipal level. Independent health departments reported that their aldermen and counselors and finance committees had a better knowledge of the roles and responsibilities of a local health department, with 30% in the shared and 40% in the independent reporting excellent or good understanding of their aldermen or counselors, and 33% of the independent reporting an excellent or good understanding of the finance committees. There were no differences in understanding between the two models in the Board of Health understanding or the Chief Executive's understanding. We also looked at the Board of Health, and in Massachusetts, there's a requirement that there be a municipal Board of Health. That requirement isn't there in Connecticut. So in Connecticut, you will have municipal independent health departments who do not have a Board of Health. All of the districts in Connecticut do have a Board of Health. So in all of the shared departments, there's Board of Health representation and a much larger average size because they're including representatives from all of the member municipalities. Interestingly, independent departments reported more meetings with the chief executive, with 59.3% meeting 10 or more times a year with their chief executive, and versus 33.3% in the sharing reporting the same. So there's some interesting distinctions, and some of that may be the sheer number when you're working with multiple municipalities to be able to meet with all of the chief executives versus working with just one. Turning to the public health staff, we asked extensive questions about staffing. We asked for a listing of all staff, their FTEs, their salary range. Then we looked at time allocation across all of the public health services and programs by each staff person. Overall, sharing departments do have a lower public health staff FTE per 1,000 population, 0.14 FTEs per 1,000 versus 0.22 FTEs per 1,000 for independents. In addition, the educational background of the directors differs significantly. Some of that is driven by the districts in Connecticut require public health training. Directors of shared service models are much more likely to have public health training and MPH degrees. In addition, in Connecticut, we have part-time health departments, which are very often, what that means is that there's a part-time health director. Very often that's a local MD or PhD filling in that role. So this is the MD PhDs being higher in the independent models is really mostly in these small towns where the Board of Health chair, for example, is serving as the health director. In looking at core public health services, we looked at 16 common core services that we drew from the NACCHO profile survey to identify the differences shown here. We also asked whether the service was offered in the municipality and by whom. These were the primary differences that we observed, that there's some that are higher in shared, some that are higher in independent. Not a consistent story here. In terms of community health programs, we also looked just at and this is at the level of the municipality. Again, we asked, is this service provided in the municipality? And that's what's represented in these numbers. it wasn't always provided by the health department. It might actually be provided by someone else, Visiting Nurse Association or another organization. There's a couple that are higher in the shared, so chronic disease prevention, obesity prevention, injury prevention, mental health education are higher in the shared. Tobacco control, substance use education and prevention, and domestic violence prevention are higher in the independent. And so this certainly would require more unpacking to really find out what the stories are around these numbers. As a number of health departments in Connecticut in particular are looking at completion of community health assessments, and anyone going up for accreditation needs to work on this, we asked about community health assessment and community health improvement plan completion in the last 3 years. And there's a slightly higher rate of playing a major role in the CHA or the CHIP in the sharing municipalities. In terms of obesity prevention activities, so we asked a number of questions, and I'm just going to give you a couple of examples. So you'll see that this graph focuses on healthy food activities, and you'll see it's high. The highest is in grocery stores, and so that's a response to a question of initiatives to promote the availability of grocery stores, farmers markets, and other fresh produce outlets in the community. That was highest in both the resource sharing and in the independent, followed by schools, which were initiatives to change the food and beverages available at schools and school-sponsored events. Grocery store and school-based healthy food initiatives are most common, and they are happening at a lower rate in the sharing, in the independent health departments. In terms of cost, the physical activity, which includes things like community-level urban design initiatives to promote stairs, use of stairs, things like that, a number of different initiatives. You'll see in the obesity expenditures per thousand that they're much higher, although for physical activity, there's a significant overlap, and so the p-value is still only 0.14, but you'll definitely see that trend, a much higher resources going into obesity prevention for the resource sharing as opposed to the independent. In contrast, the enteric disease investigation costs per thousand population were virtually identical in the independent and resource sharing departments. So one more, just a couple more slides, and then I'll turn it over to Justeen. In terms of the cost model that we developed, both the obesity prevention and the enteric disease had serious limitations in what we were able to analyze. We were able to look further in terms of the food service costing. So we asked about staff costs, indirect rates, overhead rates, but unfortunately the only thing that we could get consistently across all of the respondents were the staff costs. When we look at the cost per food inspection, it's not significantly different between the independent and the resource sharing, although you can see that the trend, 136 versus 94, is towards it being more expensive in the independent. When we looked at the key drivers of cost per inspection, the graph on the right actually shows you the total cost of inspections, and you'll note that under 500 inspections, which is the the bottom axis, it's a pretty straight line. And then once you go 500 to 800, the slope is decreasing. And what that means is that as you add more inspections, the cost is going up at a slower rate, and then it plateaus between 800 and 900. So what this would suggest is that in terms of the cost per inspection, it would basically be a mirror image that once we get over 500 inspections, we start to move into those economies of scale that are possible. And a number of our smaller municipalities aren't at that 500 or more level. So we wanted to note that the resource sharing, state, unemployment, high quality, none of those were significant predictors of the cost, of the total cost of inspections. The key piece was how many inspections were you doing, and that was the key driver of the cost per inspection. And Justeen, I'm turning it over to you.
Okay. Good afternoon, everyone, or good morning if you're on the West Coast. So I'm going to pick up, I think, just by way of background, one of the other things that we did as part of this study, because Connecticut and Massachusetts had both developed a number of research studies looking at the structure and the organization, the quality of services, and we know that during the course of our interviews, our neatly structured quantitative questions always yielded a whole lot of qualitative response. So we actually audio recorded all of our survey interviews and went through a process of, looking through the data and responses and coding that. So we had the best data around food safety inspections, which is one of the reasons why we're focusing on food safety inspections here. And we had some interesting findings from the qualitative and quantitative analyses that we conducted. So, cost is a big driver, and for both of our states, 500 inspections a year is a lot, even, unless you're in our most populous municipalities, which make up a really small percentage of all the municipalities in our states. So, so I think it's important to know that, and I think it's really important to know that for small and rural health departments, what we found in the economies of scale. In both of our states, we didn't see significant differences in the number of inspections conducted per 1,000 population. And in Connecticut, we did see, there were some variations between our two states in the proportion of inspections that are required to be conducted. So in Connecticut, the independent jurisdictions had a higher proportion of required inspections, whereas in Massachusetts there weren't differences in the number of required inspections conducted. And I will say, because I think a lot of people are interested in food safety, one of the challenges of this set of questions also came from the fact that people have use different models to set out their inspection schedule. So in Massachusetts, for example, some use the state-mandated 2 inspections per year. Others were moving towards a risk-based inspection model. So I think it's important, just for if you're on the research side of things, to be mindful of variation in these inspection schedules. So importantly, what we want to get at today is one of the anxieties that we had when we started this project was that we might look at cost and the number of inspections conducted, but you could do something for less amount of money and do a poor inspection and have it turn out to look like you're faring better, you're more efficient, and you're doing more. So we really wanted to include some quality indicators for food inspections. And the FDA Voluntary Retail Food Safety Program has a number of quality indicators that we've adopted in previous studies and we used here. So, what you see in front of you is 8. We looked at 8 quality criteria, everything from formally trained inspectors, opportunities to participate in ongoing training, using standard inspection reporting forms, important written standard operating procedures, designated supervisor to oversee inspections, written policies for responding to complaints, having all the equipment needed for food inspections, and then conducting at least minimally an annual evaluation of the food inspection program. So those with asterisks are the ones that were most commonly reported across both models. So one of the things that we did find is that sharing departments are more likely to have 5 or more of the quality indicators. So, and that was significant. So the blue bar line are the independents, the orange is the shared, and you can see that as the number of quality indicators go up, those in shared departments were more likely to have report more quality indicators. And some of that is due to the fact that the question, for example, let me just go back here, having a designated supervisor to oversee food inspections. In many of the independent departments that are small, there was just one person that was doing everything, and so there was, they said there was no supervisor to oversee their work. So some of those quality indicators were driven by the size of the department. So some observations that we gleaned from listening to the conversations when we asked these questions during our interviews. Formally trained food safety inspectors in Connecticut require standard training of all food inspectors and ongoing training. In Massachusetts, this varied widely in terms of formal training. Both states use the state's standard inspection form, and nobody really said that having the equipment was a challenge for their departments. So those that reported that they had written standard operating procedures were most likely to say in their narratives that they were working towards or they'd achieved public health accreditation, and or that they had enrolled in the FDA's Voluntary Retail Food Safety Program, and that was one of the recommendations and requirements of that program. And then I already mentioned about the supervisor, that there, in departments with only one, most people in smaller departments said that wasn't even possible. Now, the evaluation, it might be just because I do a lot of evaluation work, but the responses to whether or not people had an evaluation of retail food safety program was really interesting. People conceptualized evaluation in a lot of different ways. Some people said that their evaluation consisted of looking at past inspections to identify trends and violations and repeat violators. Others considered their evaluation to be looking at the forms to make sure that all the fields are completed and so there's quality in the completion of the forms. And then others had sort of a range of formal to informal conversations with inspectors and staff to identify the strengths of their work, the challenges, and areas in need of improvement, and often in terms of how they're organized and able to meet the mandates. So there was a lot of variation. Again, if we're, to want to have people operating with the same assumptions when they answer these questions. We want to keep these things in mind. And then in terms of reporting on food inspections, most of the people noted that their report was a count of inspections and re-inspections, and that was primarily what they did. And often in Connecticut, it was always to the state. So some observations that we came up with about the similarities and differences between Connecticut and Massachusetts. Again, we really tried to reduce the variability across sites, but for different states. So, among those health departments with single municipality health departments, smaller independent municipalities in Connecticut tended to be wealthier than the ones in Massachusetts, and that might be a difference. There was some difference in reported capacity to hire qualified staff, so that may account for some of the differences there. In multi-municipality jurisdictions, Connecticut districts are standalone, whereas in Massachusetts they're usually anchored to an entity or a municipality, one of the municipalities. So as a standalone, I think our Connecticut colleagues thought that that really does affect the day-to-day involvement in municipal decisions because they sit independently. It affects the relationships across towns. And it allows for some differences, some protective and not for those political fluctuations that tend to happen at the local level. And then across all of our participants, health directors reported that they have a ton of challenges with dealing with the variable understanding of the roles and responsibilities of health departments. And in Massachusetts, I'll just add that that requires a lot of energy, time and energy of the health directors as they work with each jurisdiction in their group to make sure that there's an understanding of roles and responsibilities. Okay, so in terms of some conclusions, we found that independent health departments did report that their governing bodies have a greater understanding of the roles and responsibilities of local public health. In both models, we really noted that those services that are state mandated really drive the provision of public health services. So they were more likely to see public health services that are mandated than not. In terms of potential efficiencies, shared service departments have fewer staff per 1,000, and there weren't huge differences in the breadth and cost of services being delivered between the two models. And then shared service departments were more likely to have directors with public health training. And that was particularly true in Massachusetts because it's all required in Connecticut. Shared service departments were a little bit more likely to report providing some more community health programs and services. They are more likely to invest in activities that promote access to healthy food. And there were no differences in enteric disease investigation. And I think Debbie didn't note that the enteric disease data were mostly from Connecticut because we had a hard time getting those data in Massachusetts. The sharing departments had more indicators of higher quality food inspections. And then finally, cost, which is big for both states, you know, from the health department and the municipal governance perspective. The primary driver of food safety inspections is the total number of inspections, as Debbie noted. And that sharing, we didn't find independent or sharing departments, the model was not significantly associated with cost, which is one of our hypotheses. And we were asked to know what we thought our contributions to the field were with the study. So for both of our states, we thought this study adds to the limited research on effective and efficient service delivery models for small and mid-sized jurisdictions. We really believe strongly in incorporating quality measures into services when we're doing research on local public health services. They're really tricky. We spent probably the bulk of our time trying to figure out what those quality measures would be. And if you have the time and resources, audio recording your interviews is really interesting and well worth it. You learn a lot from doing that. And then we think that this study extends previous research on the cost of local public health services by exploring some of the potential variations in costs by jurisdiction size and service delivery model. And with that, I will wrap up by saying that in a previous webinar, we had highlighted some of the trade-offs that public health directors noted in their service delivery model. And we see that each model has a trade-off. We didn't come away from this study with a strong sense that one was better than the other. The size of the jurisdiction does matter. I think local independent health departments serving small jurisdictions do have limited resource, but a strong local knowledge, whereas multi-jurisdictional models have more resources but often require more time and energy, investment in governance and decision-making. And so when making decisions about the right service delivery model for a given jurisdiction, you really want to give careful consideration to local culture and values and figuring out what matters most to constituents in terms of what is expected and wanted out of local public health. And with that, I'm going to conclude our piece.
Thank you, Dr. Hyde and Dr. Humphries, for that very interesting presentation. There's a lot to think about, and I'm sure the folks who are listening have been coming up with questions as you've been talking. I invite you to go ahead and enter those questions in the chat box. We will get to those momentarily. But first, I have the privilege of introducing our two respondents from practice. Mr. Steve Huleatt is the Director of Health for the West Hartford-Bloomfield Health District in Central Connecticut. Mr. Huleatt's public health career began in environmental health in 1979. He was appointed the health director for the town of West Hartford, Connecticut in 1989 and appointed the health director of the West Hartford-Bloomfield Health District upon its formation in 1995. Following Mr. Huleatt, we'll be hearing from Mr. Ron O'Connor, who is the Director of the Office of Local and Regional Health for the Massachusetts Department of Public Health. In this role, Mr. O'Connor leads the OLH team and collaborates with external stakeholders, including the Massachusetts Coalition for Local Public Health and an intra-agency local public health working group to strengthen local public health capacity through workforce development, regular communication, intra-agency collaboration, and support for intermunicipal collaboration in the delivery of local public health services. We look forward to hearing from both of these gentlemen. As I said, as they're speaking, please do enter your questions in the chat box, and I will hand the mic over to Mr. Huleatt.
Good afternoon and good morning and good day to everybody from Bloomfield, Connecticut. Just several quick comments that were both brought up by both Debbie and Justeen. Under administration and governance, there was that model that was indicating sort of an orientation. In a municipal setting, you tend to be much more focused towards that municipal home rule side, as Debbie was telling us. As you move away from that towards the shared services, you get more state-centric as you take on the state public health code and more of those mandated state requirements. And I bring that up because it's important that you stay connected to your communities. You can't lose your communities. So what you see then is some of those shared services really try to get more active with community engagement projects, such as perhaps the obesity type of work that we saw, which may or may not explain why there seems to be more obesity work going on in the shared districts. And then there's actually a need to actually immerse yourself in that community so they know that you are their health department. You are not some outside agency. You are their health department and that you care. The evaluation piece, I just reiterate what Justeen was sharing. I think that for way too long, all we've done is collect output data, mainly to funders or funding sources to say how many of these things we did, and people can do traditional cost analysis of what it costs per output. But really we need to move towards outcomes as we start using more quality improvement processes. And the outcome is health. And the data doesn't necessarily give us health measures. It tells us how many things we did, how many widgets we made. So I think that's something that we're all striving to get to, but we don't have a common numerator or denominator for those outcomes at this point. I briefly talked about responsiveness and connectivity are quality measures that in our working on this project, I think we went round and round and round with trying to figure out how do you measure those and what's good. And the smaller health departments have more flexibility. They can change course and directions quicker than the big ones. That's been found in other literature and studies. And fees for service, we didn't talk about it in today's presentation, but the shared service it's easier to charge an appropriate fee for the cost of the service because you're outside of the political influences of the municipality. The elected officials get very nervous when the constituents say, hey, you're charging us too much. Whereas in the district, that's determined by the board of directors for that district, and it's a little bit more insulated from that issue. And the towns tend to support that fee because it lowers their contribution or lowers the bill that might be shared with the municipality. And my last point would just be that on the community health side of the equation, the districts have an advantage over their municipalities. The old saying about municipalities really being short-term planning is budget year to budget year, and long-term planning is 2 years election to election. So it's easier for a district or shared service to make a 5-year commitment to a program like obesity, even though 5 years wouldn't be significant enough to probably see a change necessarily in a generation. But it's easier for that district and that board to put that in a strategic plan and say, this is what we're going to do, because it won't be subject to changes in the composition of the elected officials. And with that, I will stop there.
Thank you, Mr. Huleatt. Mr. O'Connor, your thoughts? Mr. O'Connor, you may be on mute. Could you please check your phone? All right. We appear to be having some technical difficulties with Mr. O'Connor's line, so we will try to resolve that backstage while we continue moving forward, and hopefully we'll hear Mr. O'Connor's comments in a moment. But in the meantime, let's go ahead and introduce some of the questions that we've been hearing from the attendees at today's webinar. And if these spur some thinking on your part and you would like to add some questions into the chat box, please do go right ahead and do that. Our first question comes from Gianfranco Pizzino. How do you explain the finding that aldermen or counselors had more knowledge of local health department functions in independent local health departments?
This is Debbie, and I'll go ahead and take that question. I think that it is basically what Steve was alluding to, that when you have an independent department, they're going to be very focused on the local municipality. They're going to be negotiating their budget with the local municipality. Educating the local legislators is essential for getting the funding that they need, whereas when you shift into the shared arrangements in Connecticut, they're the funding is more at the per capita. Each municipality pays a set per capita fee, and so it's a very different arrangement than in an independent municipality. And that going along with those negotiations does come the opportunities to educate the local legislative staff and the finance committees on what's needed for high-quality public health. Would you add anything, Justeen?
Yeah, the only other thing that I would add is that in the independent, I think it's important to remember that in the independent health departments in our sample, most of them are small towns, so 5,000 or less, and so by virtue of working in the town, people talked in our interviews about running into people, having informal conversations. So they're located in the municipality, and they're having formal and informal conversations about local public health issues in ways that I think in Connecticut, because they sit independent, they're an independent entity, they're not roaming around the halls in town hall, usually, I think. And in Massachusetts, the shared services, they varied a lot in terms of, I know like Phoebe's Walker's on the phone, and up in Franklin County, I think they do a lot, they put a lot of energy into going to meetings and being present, but there's a lot of variability in how much time people spend at the local level when they're involved in shared services. So I think that's how I would, yeah.
Thank you both. I think Gianfranco's question points to the ways in which good research not only answers some of the questions we start out with, but really helps us create new ones to continue exploring and better articulating and exploring and finding answers to, and that is the job of research in many ways. Before we move on to the next question, I just want to check, have we gotten hold of Mr. O'Connor yet? Are you back on the line?
He's in the process of dialing in.
Okay, well, we'll move on to the next question and then hopefully loop him back in just a moment. We have a question from Phoebe Walker, who asks, how did the context of Connecticut's state funding and education requirements impact your ability to compare them with Massachusetts?
And I would just say that we noted, for a lot of our findings, we noted the difference. So we noted that independent health departments had more MDs and PhDs, and shared had more training with MPHs. And then we went and looked for the reasoning, and some of that, and the differences appear to be primarily driven by some of these statutory issues in Connecticut. So all we can say is that when we see the differences, these are some of the reasons that we attribute the differences to.
I'll add on that, though, too, that, Phoebe, one of the things that was striking for us, I think one of your questions, or one of the things you're asking is, because Connecticut, the State Department, provides funding to local public health, what is that impact? And from a research perspective, I think Connecticut had better data that they could leverage and pull on. They could, because the state provides funding, public health jurisdictions are required to report on an annual basis, so there creates more information to assess and do research at a state level. So that was one difference between our two states. The quality of the data and the access to data varied. And we tried to compensate for that. to varying degrees of success. And then as like the education requirements, certainly we saw in Connecticut, all the directors have public health training, where that wasn't the case in Massachusetts. So we did find those differences.
Thank you both. I believe we are still working on some of those technical issues with Mr. O'Connor.
Yeah.
Hello?
I had some problems with my desk phone. So,
all right, excellent. Well, we are looking forward to hearing your comments, and I hand the mic to you, sir.
It's not, I'm sorry. It's just, it kept dropping out on me. So if you don't mind, I'll try again. Okay?
Please do.
You can hear me now. Sorry about that.
Yeah.
So thank you for the opportunity today. And so the research that was reported today will help us to move forward with a more efficient and effective local public health system in Massachusetts. I want to, in the interest of time, I think I'll jump through some of my comments here and just summarize. The Office of Local and Regional Health in the State Health Department of Massachusetts is relatively new, and we're focusing on enhancing and strengthening our relationship with local public health and building a more robust local public health system. We have programs and staff across the department, and we work to provide a collaborative and cooperative framework for all of those programs to work together. One of the exciting things that's happening is that the Special Commission on Local and Regional Public Health, which was created by an act of the legislature in Massachusetts last year, will be convening soon. And their purpose will be to assess the effectiveness and efficiency of municipal and regional public health systems and to make recommendations on how to strengthen the delivery of local public health services in Massachusetts. And so among its tasks, the Commission is going to look at research that is available on the structure and organization of local public health in the United States. Given the very limited research focused on small and rural health departments, the study presented today adds to the small body of literature and will be part of the discussion by the Commission. And of course, it helps also that Justeen Hyde is a member of that Commission. One of the things I wanted to comment upon is public health nursing services and the findings related to that in this particular study. Regional local public health groups in Massachusetts were much more likely to have public health nursing services on staff rather than contracted than in Connecticut. In Massachusetts, we have a strong commitment to public health nursing services at the local level and funded at the local level. One general observation from my experience in Massachusetts is that sharing public health services is often a place where communities start a conversation about sharing services. The contracted versus staff public health nursing services also raises a possible research question about differences in scope and quality of public health nursing services. For example, are staff public health nurses more likely to be engaged in broader community health programs than nurses contracted through a visiting nurses association? Additional comment is I noted that the breadth and quality of services when moving from an independent to a shared service model, that there's no reduction in the breadth and quality of services. And that information will be valuable to us in Massachusetts because it suggests that there are important efficiencies that can be achieved in moving from independent to shared service models. The ability to deliver local public health services more efficiently may allow a broader scope of services to be delivered with existing resources. We see shared services not as an opportunity to save money in the delivery of local public health services, but rather to broaden the scope of work to encompass the 10 essential services. Those efficiencies in the broader scope can also position shared service models to apply for and obtain extramural funding, for which they might not otherwise be eligible because of population size or staff capacity requirements. And we've seen that the shared service model can leverage external funding in many of our shared service communities, particularly in the areas of community health promotion and wellness. And given that for example, one of our shared service communities, the Massachusetts Public Health District, has been very successful in acquiring funding from external sources around tobacco control and opioid use prevention. Finally, one of the questions that I think we have that might be a future research question is, in Massachusetts, we have communities in which inspectional services are located separate from the health department. They're located in a different department within the municipality. And I think It's important, as we look at it in Massachusetts, which is the more effective model, and I think an important part of that is the extent of communication between the inspectional services and the health department. And that sort of speaks to some of the experience in the larger communities or the independent communities where communication and collaboration with municipal officials was more of a challenge than in the shared service models. So I'll stop with that because I'm sure there are people with questions. And again, I apologize for the telephone challenge.
Thanks so much, Mr. O'Connor. We appreciate those terrific insights. And we do have one more question teed up. I know we're starting to get close on time, but I want us to try to get this in. It is from Elaine O'Keefe, and it is for Steve Huleatt. She asks, your long-lived experience at a local health department and insight on the nuances of local health department organizations that are independent, municipal versus multi-town or shared scope is invaluable and great contextual considerations for understanding the findings in this study. Was there anything in particular that came out of this study that you would find useful specifically to inform ongoing discussions in our region about increasing shared service or larger service area local health departments?
Well, that's a whole research question in itself, Elaine. I mean, I think the issue, and even listening to Ron speak just now, I was thinking about this. You know, in the small independent, the task often is, or even when we looked at the core service slide that was presented showing independent, there was an array of different types of services that were being provided by the health department. Animal control, I believe, was one of them. You know, could be recycling coordinator, could be this, could be that. Not all of those necessarily are directly public health. I'm not saying that they're not, because public health is a broad umbrella. But I think one of the things that needs to be considered is having dedicated public health staff. And I don't think our study really got to what size do you have to be to have that dedicated core public health staff. And I don't think we have that guidance for Ron in Massachusetts any more than we have it for us here in Connecticut. But I do think that dedicated public health staff doing the dedicated public health work becomes really important, because if you are doing other services, it's taking you away, no matter how you look at it, from perhaps doing the food service inspections, perhaps doing obesity programs, hopefully not from doing your enteric disease investigations, because you should be doing those right away. But you know, you can't really tell what thing is important at that point in time to your first selectman or your mayor. So I think that would be my key. One point that I'd share with Elaine and for all of us in the region and all of us in New England for that matter is, you know, what should that core public health service be and dedicated to it? Maybe in a small town it is just one person, but or maybe it's a shared person. Just doing that for those two towns. So I don't have the equation, but I would argue for that more full-time presence to address the issues as they come, and to bring public health into all policies in the town. Sort of that engagement piece I was talking about before, and connectivity to the municipality. So that hopefully anybody else wishes to comment, please do so.
Thank you so much, Mr. Huleatt. And I see that we are near time, so I just want to take a quick moment to remind everyone on the line that if you want to follow along, access additional products from this study, they are available on the Public Health Services and Systems Research website. As you see here, there is a project page that contains more information about the study, as well as presentations, and we'll keep that updated with information as it becomes available. I also want to encourage you to think about joining some of our upcoming webinars, as Dr. Humphries alluded to, with that early finding about community health programs and how that delivery grows when we engage in different kinds of collective action solutions. In this case, cross-jurisdictional sharing, in some cases cross-sector collaborations. We are working in these different areas toward a more comprehensive population health delivery system, and we are sharing upcoming webinars with you that address those problems in some very specific ways and areas. So coming up on Wednesday, June the 14th, we're going to hear about cross-jurisdictional sharing arrangements between tribes and counties. specifically for emergency readiness. And then the following week, we have a webinar on accountable community of health structures and cross-sector coordination. So we do hope you will consider joining us for one or both of those. As always, we can be reached at this address. We want to thank Ann Kelly on our staff who does such a great job putting this webinar series together. The systemsforaction.org website is there, and we do have a Twitter handle. We hope that you will follow us on social media. Many thanks to everyone who worked so hard on this webinar, including our terrific speakers, Drs. Humphries and Hyde, and Mr. Huleatt and Mr. O'Connor. Systems for Action, as I mentioned at the top of the hour, is a national program office of the Robert Wood Johnson Foundation. Thanks for joining us. We look forward to hearing from you soon. Have a great day.